Welcome to Airway Breathing Conversation, a podcast presented by the anesthesiology residents at the University of Saskatchewan, created to provide individuals of all levels of medical knowledge with anesthesiology-related healthcare information. This episode is part of our Abridged Ground Round series, in which highly knowledgeable and sought-after guest speakers present on a multitude of fascinating topics relevant to anesthesia. Join us for Grand Rounds this week, where Dr. Juliet Atherstone, a cardiac anesthesiologist at Vancouver General Hospital, and Dr. Sarah Parent, a cardiologist in Saskatoon, discuss heart failure assessment and management in the perioperative setting. Now, whether you are an anesthesiologist, resident, medical student, or member of the general public, come listen in as we demystify the incredible specialty that is anesthesiology, one episode at a time.
So we're going to discuss how to circumvent failure in your heartless patients for non-cardiac surgery, and hopefully how to evaluate them preoperatively to decide the safest approach for your patient. And with that, I'm going to turn it over to Juliet, who will start us out.
Good morning, everyone. And thank you for having me. Thank you for inviting me. I'm a little jealous of the snacks, but and we're an hour earlier here, so forgive me if my brain isn't quite switched on as much as it should be. We have no disclosures for this talk. These are our objectives. We're going to discuss guideline-based assessment of cardiovascular patients for non-cardiac surgery. We're going to talk about preoperative risk assessment and the 3 factors to consider with this. Then I'm going to hand over to Sarah, who is obviously our heart failure specialist, to review the definition, diagnosis, and etiologies of heart failure, and review recent updates to the medical management of heart failure and preoperative medication management. And we're kind of both going to discuss heart failure, perioperative risk assessment, optimization, and management, and the most important thing for high-risk patients, which is complex shared decision-making. My first key message is to learn to love the guidelines. The European Society of Cardiology, CCS, AHA, all put out guidelines to try and help us manage patients going for non-cardiac surgery with cardiovascular issues. And they seem big and very wordy, but they're actually really well laid out with lots of tables that help us make decisions for any issue you can think of. And a lot of my talk was based on the 2022 ESC guidelines, because I found those really comprehensive and useful, easy to read. And then they have heart failure guidelines as well. And then Up to Date had a lot of great reviews on a lot of the topics we're going to discuss. So here's a little stem for the day. Yikes, your patient has an EF of 20% coming from moderate risk non-cardiac surgery. So when I'm an ACC, I don't know about you guys, but this is how I feel on the inside when I start reading this patient's chart. And it's mostly because of the time pressure that we're under, and that these patients can be so complex, and a lot of the issues in decision-making hasn't been done ahead of time for these patients. So it warrants a lot of workup and discussion that we don't always have time to do. Why is this topic important? And as we'll see over and over in this presentation, heart failure significantly increases perioperative morbidity and mortality in non-cardiac surgery, and currently thought to impact nearly 1/5 of patients going for major surgery. And this is predicted to increase as therapies get better and we see more and more patients with heart failure living longer. One of the key messages, and you'll see these key messages throughout my presentation, is that perioperative cardiovascular complications significantly impact patient prognosis. So heart failure patients are at risk of these complications, and these complications are bad. They account for 1/3 of perioperative deaths, morbidity, hospitalizations, increased cost, and poor prognosis. And the risk is obviously highest when they first come out of surgery, but they remain high for about 3 to 5 months after surgery. And we know the cardiovascular complications of patients with heart disease are all these things. They're bad. And as I mentioned, heart failure patients are particularly high risk across a broad range of surgical specialties. I kind of like this figure. It just sort of puts it all together with the comorbidity risk, the thrombotic bleeding risk of surgery, the hemodynamic arrhythmia risk, and the hypoxemic, hypotensive, hypovolemic risk, all of which are particularly bad for heart failure patients. And then in the middle, that all plays into what the surgical risk is. We know surgery is stressful. There's the stress response, the neuroendocrine response, the imbalance of myocardial oxygen demand and delivery, and all the factors that contribute to this, and also the prothrombotic state. This stepwise approach was kind of buried in a paragraph in the ESC guidelines, and I thought it actually really summed up the process really nicely. So what we need to do for these patients is integrate the clinical risk factors, test results, the estimated stress of the procedure, and the risk of discontinuation of drugs. And using all of that, do an individualized patient risk assessment. Add that to patient values, preferences with respect to goals of care, and come up with shared decision-making to make the best decision for that high-risk patient based on their wishes. So an individualized risk assessment is important because it contributes to this informed decision-making and helps with decisions about, is this surgery appropriate for this patient? Is there a less invasive approach that we can take? What management decisions should we undertake? Do they need further investigations, treatment, referrals? What site would be best to treat this patient at? And what sort of monitoring we need intra and post-op? So that's where sort of risk assessment comes into play. So how do we do an individualized, accurate risk assessment for our patients? And there's a rainbow in this slide for a reason. It's a great goal, but it can be really, really elusive and difficult to do because every patient's circumstance is slightly different. But we're going to talk more about that. So a good place to start is to assess and integrate the 3 pre-op factors. The factor 1 is the type of surgery or the procedure. How risky is it? Factor 2 is the circumstances under which the surgery takes place, emergent, elective, etc. And factor 3 is all the patient factors that play into this. So in the STEM that we got, we know 2 out of 3 factors. We know it's moderate risk surgery, but what does this really mean? We don't really know the circumstances. And all we know about the patient is that the ejection fraction is 20%. But this 20%, there's a lot of missing information about how risky this 20% is for this patient. And how do we kind of tease that out? And what else do we need to know about the patient? So let's start with factor 1, the surgery type. So a key message is quantification of surgical risk is helpful in identifying patients who would most benefit from further investigations and treatment. So the surgery type or the surgical risk is used in the algorithms to decide when to further investigate cardiovascular issues. For example, they mostly recommend further investigations or treatment if the surgery is high risk or moderate risk. So you've all seen these tables before. Surgical risk estimate according to the type of surgery intervention. Intermediate risk surgery, things like a cholecystectomy, major uro or gynae surgery, or hip or spine surgery. Surgical risk estimate is the 30-day risk of cardiovascular death, MI, and stroke, or MACE, major adverse cardiac events, but it takes into account only the specific surgical intervention. So all comers for moderate risk surgery have a 1 to 5% risk of major adverse cardiac events. So that's a pretty quick and easy way to look at your patient's risk. What about the circumstances? Another key message from ESC is the proper selection of type and timing of the surgical procedure may reduce risk of complication. As we'll see later, emergency surgery is much higher risk, and the risk prediction models are not as accurate for emergency cases. And then when you think about site selection, what are the backup and bailout options for this patient, and are they available in your center? This this paper in the Journal of Cardiac Failure looked at emergency versus elective surgery mortality in heart failure patients at 30, 90 days in 1 year. And as you can see, there are orders of magnitude higher for emergency surgery, up as high as 40% at mortality at 1 year for emergency surgery in heart failure patients. And they concluded that patients with heart failure have a substantial mortality risk, and heart failure is both a risk factor and a strong marker for increased risk. So let's move on to factor 3, the patient factors. Heart failure is a big risk factor. And why is this? Because we're worried patients undergoing surgery have decreased reserve, and they risk acute decompensated heart failure, which means rapid onset and worsening of symptoms and signs of heart failure. And this can be precipitated by all the things we talked about and all the things that happen under surgery. So we're worried about this patient. How worried should we be about the heart failure? What else do we need to know? And what else will change their risk? And I am going to move on to our heart failure specialist, Dr. Perrin, and she's going to let us know a little bit more about this.
So just taking it back just a little bit, what is heart failure? So this is a clinical syndrome that has cardinal symptoms that you're all familiar with, like breathlessness, ankle swelling, exercise tolerance, and fatigue. And they have often typical signs such as an elevated JVP, crackles, or peripheral edema. And it's a result of many different pathologies of the heart, but ultimately a structural or functional abnormality of the heart leads to elevated intracardiac pressures and or inadequate cardiac output at rest or during exercise. And we break it down into chronic heart failure and acute heart failure. And the reason to distinguish these two, at least for you guys, is that the risk profiles of your patient between chronic and acute heart failure is quite different, with acute heart failure being a much higher perioperative risk. So those with chronic heart failure are those with an established diagnosis of heart failure or who have had a more gradual onset of symptoms, versus acute heart failure where they would have new or sudden rapid onset of symptoms that are often severe enough to seek urgent medical attention, and this is a common cause of unplanned hospitalizations or emergency department visits. And within that, we talk about decompensated heart failure, and those who maybe had previous chronic stable heart failure with now sudden worsening or gradual deterioration of their symptoms, which may lead to hospitalization or need for IV diuretic therapy. It's further classified based on ejection fraction, mainly because different treatments have been shown to benefit patients based on their ejection fraction profile. And so what we're talking about, or we're more focused on today, are those with heart failure with reduced ejection fraction. Those are patients with ejection fractions less than 40%. We have another category called mildly reduced ejection fraction. Those are patients between 41 and 49%. Heart failure with preserved ejection fraction, or those with ejection fractions over 50%. Obviously, these can be normal individuals. So if you have an ejection fraction over 50%, to be a HFpEF patient, you have to also have signs and symptoms of heart failure, and usually you will have functional abnormalities on imaging such as LVH, left atrial enlargement, impaired LV filling, or raised natriuretic peptides. So you can't just label everybody out there with heart failure with EF over 50. Otherwise, we all have heart failure technically. So those signs and symptoms and structural abnormalities are important to that diagnosis. And then lastly, recovered ejection fraction, are those with previous ejection fractions less than 40% who have now recovered. We do recommend ongoing heart failure treatments for them to prevent decompensation. So Heart failure is actually increasing in prevalence because of an aging population and better treatments for other cardiovascular disease. So you survive your MI or you survive your valve surgery, but that allows you to survive long enough to then potentially develop heart failure. And better treatments for heart failure have also resulted in prolonged survival. And so about 3.6% of Canadians over the age of 40 live with a diagnosis of heart failure. And you can see that the prevalence increases with age, so that if you have a patient walking into your pre-op clinic who's over 80, there's about 20 to 25% chance that they have heart failure. Fortunately, the incidence of heart failure is actually on the decline, with about 5 per 1,000. Being diagnosed with heart failure per year. What's the prognosis? Mortality is declining for heart failure. One study showed, rate of decline from 78 to 58 per 1,000 between 2000 and 2012. But still, Canadians over 40 were 6 times more likely to die of any cause compared to somebody without heart failure. And if you look at heart failure with reduced ejection fraction versus preserved ejection fraction, you can see that even with heart failure with preserved ejection fraction, your mortality is still quite elevated at 5 years at about 67%. The only difference is a slight difference in whether you die of a cardiovascular versus non-cardiovascular cause, with those with HFpEF being a little bit more likely to die of a non-cardiovascular cause. Hopefully, the contemporary data is going to look a little bit better as this data precedes some of our newer advances in heart failure medications. How would you diagnose heart failure if somebody comes into the PAC clinic and maybe they've got a few symptoms that are like, they don't have that label on their chart, but maybe they have some dyspnea and they've got some peripheral edema. So you'd want to look at, do they have typical symptoms? Do they have other specific signs of heart failure, such as that elevated JVP, a gallop, a displaced apex? Have they been gaining weight? Do they have crackles, that sort of thing? Most patients with heart failure will have other risk factors for developing it, such as a prior MI, hypertension, coronary disease, diabetes, substance use, etc. Their ECGs will usually be abnormal with things like LVH, a wide QRS, AFib, sinus tachycardia, or Q waves. And then the BNP is a quite useful marker to rule out heart failure if it's normal. And we typically use the NT-proBNP here at our site. So if it's less than 125, that's usually pretty good at ruling out heart failure in your patient. However, I caution you, it tends to be disproportionately low in your obese patients, so watch for that. And then not all raised BNP is heart failure. So there are age-specific cutoffs because the BNP increases with age. So look at the age norms for the BNP. And then other conditions like renal dysfunction, AFib, stroke, anemia, cirrhosis with ascites, sepsis, etc. can all raise your BNP. So it's not a slam dunk label. So it's better as a rule out parameter. If you're suspicious, the next step is an echocardiogram, and that will further allow you to establish the phenotype. Are they a HFrEF versus a HFpEF? And obviously, if the echo is normal, then they probably don't have heart failure, and you should consider other diagnoses. Once you've diagnosed heart failure, you want to think about the other etiology. And in your pre-op clinic, even if they already have a label, it's important to think about what caused their heart failure, because those are things that you may also have to consider in your pre-op management plan. So things like coronary disease, you want to make sure that they're not having any ischemic symptoms. Do they have hypertension? Do they have valve disease, which could lead to pulmonary hypertension, that sort of thing. So think about what might have caused their heart failure and whether that is optimized as well. We classify patient severity of heart failure based on what they're able to do from a physical activity point of view. And you guys are probably all quite familiar with the NYHA scale, with class 1 patients having no limitations to their physical activity, to NYHA 2 having a slight limitation to their physical activity, class 3 being marked limitation. They're comfortable at rest, but anything less and minimal activity will cause symptoms. And then our NYHA4 patients who are unable to carry out any physical activity without symptoms, and they often are symptomatic even at rest. So we'll move on to how do you tell if they're optimized? So to know whether they're optimized and being treated as well as possible, here are the optimal treatment guidelines, the most current ones from the Canadian Cardiovascular Society. So the new standard of care is what we call quadruple therapy. And so any patient with an ejection fraction less than 40% should be on 4 pillars of medication. And so that includes an ARNI, ACE or ARB, a beta blocker, an MRA, an SGLT2 inhibitor. And then after that, you can go on to potential additional therapies that may have benefit. And then there's stuff that you want to be doing all through their care, such as advanced care planning, non-pharmacological education, diuretic therapy as needed, and treating other comorbid conditions. So our patient has an ejection fraction of 20%. So he should be on quadruple therapy, one of those ARNI, ACE, ARB, beta blocker, MRA, or an SGLT2 inhibitor. All these medications have been shown to improve heart failure symptoms, decrease the risk of heart failure hospitalization and death. Obviously, they may require additional diuretic therapy, ideally at the lowest dose it takes to maintain euvolemia. And I have a lot of patients, even with ejection fractions of 20, because of the 4 medications that don't need any furosemide. Non-pharmacological therapies, we do try and educate them about how to monitor and manage their diuretics, their weight, counsel about avoiding excessive salt and fluid intake, but on the flip side, not to get dehydrated, and the benefits of regular exercise and cardiac rehab programs. Again, we want to optimize other cardiovascular risk factors and comorbidities that can cause decompensation, such as AFib, CKD, anemia, functional MR, etc. And then pertinent to this question is, have you had discussions about advanced care planning? Do they know their prognosis? What are their wishes and what are their goals of care? And that's going to be especially important when facing the a potential operation, whether the benefits of that surgery make sense given their prognosis from their heart failure. So I'm going to focus on some of the newer heart failure therapies that you may or may not be familiar with. I have a small group here in the audience, but I'm wondering how many of you have had somebody on Entresto come into the pre-op clinic? Show of hands. Has it come across yet? Yeah, 1. Okay. So so it's not very common yet, but I think we've been using it since about 2016, 2017. So your reduced ejection fraction you should be seeing some of them come in on this medication. So it's a combination of sacubitril, valsartan, and it was validated based on the Paradigm trial. And basically, it showed that compared to enalapril, it reduced heart failure hospitalizations and death, and also reduced or improved quality of life. There was less hyperkalemia and slower rates of kidney decline. The biggest difference between this drug versus your typical ACE and ARBs is the amount of blood pressure reduction. So it tends to be, can cause profound hypotension. So we often will start them on an ACE or ARB first, make sure they can tolerate it, and then transition them over to the Entresto. But I do have patients that blood pressures just won't tolerate being on this medication. How does it work? Well, you guys are all probably fairly familiar with the valsartan component as an ARB, but the sacubitril is a neprilysin inhibitor. And neprilysin in our body deactivates a variety of bioactive substances, which can be beneficial in heart failure, like our natriuretic peptides. And so by inhibiting it, allows more of these substances to circulate. And basically, the net effect is it causes peripheral dilation. It decreases your sympathetic nervous system activity. It increases your parasympathetic nervous system activity. Causes increase in natriuresis and diuresis, favorable cardiac remodeling with less fibrosis and hypertrophy, and there's a reduction in arrhythmias as well. Moving on to the SGLT2 inhibitors, you may be more familiar with these because it was initially developed as diabetic drugs, and then similar to penicillin, there was an oops moment where they said, hey, this is actually reducing heart failure. And so then came the heart failure trials, DAPA-HF, which included diabetics and non-diabetics. And basically, when added to that core, which used to be triple therapy, to your ACE, beta blocker, and MRA, when you added dapagliflozin versus placebo, this caused a reduction in death and heart failure exacerbation, heart failure hospitalizations. The same is true for empagliflozin or Jardiance. Again, similar trial design, ejection fractions less than 40, diabetics versus non-diabetics, reduction in cardiovascular death and heart failure hospitalizations. Why are they beneficial to the heart? Well, we're still trying to figure that out. It acts on the proximal tubule of the kidney where glucose is mainly absorbed, results in more glucose excretion, which then results in some diuretic and natriuretic effect. It can lower blood pressure a little bit, reducing afterload. And then it's been shown to change the energetics of the heart with more ketone metabolites being used in the heart, and that is actually more favorable for cardiac function. And so we've seen improvement in myocardial energetics as well. But like I said, this is an area of ongoing research and study as to exactly how these are benefiting the heart. And then the ones that you've been used to because they've been around a very long time, just a few points. The beta blockers that reduce mortality are carvedilol, bisoprolol, and metoprolol. So we favor these beta blockers in heart failure patients. They've been shown to reduce mortality and hospitalization. And it is shown that if they get held in hospital around that perioperative period, there is an increased risk of death and hospitalizations. The only caution is to be careful with new initiation of the beta blockers because it can cause decompensation in somebody who's already decompensated. And so you want to wait to start this until they're optimized and euvolemic. The MRAs, spironolactone and eplerenone, have again shown to reduce mortality and heart failure hospitalization. There used to be some nuances in ejection fraction that you would start and post-MI versus not post-MI, but the guidelines has simplified and just said everybody less than 40, and obviously anybody on these medication, you want to make sure, check on their renal function and their potassium levels. There are some additional medications that are added under certain circumstances that you may, digoxin, tried and true, and used for those with heart failure and AFib for rate control or NYHA3 symptoms despite their optimal medical therapy. Hydralazine and nitrates are used in patients who are unable to be on an ARNI, ACE, or ARB. And then I just will talk about ivabradine and vericiguat because they're sort of new and you may be less familiar with these. So ivabradine is a cool drug. It inhibits the funny channel current in the sinus node, so you have to be in sinus rhythm for it to work. But what I really like about it is it lowers your heart rate without dropping your blood pressure or decreasing contractility like a beta blocker would. So I often use it basically when again, you're still trying to reduce the heart rate, but they're limited in terms of the beta blockers causing hypotensive lightheadedness or orthostatic changes, then we'll add ivabradine. And so this drug has been shown to reduce cardiovascular death and hospitalization, although primarily driven by hospitalization reduction. And it can be used in those who are unable to take a beta blocker, and it has still shown benefit in that scenario as well. Vericiguat, I doubt you'll see. I have yet to prescribe this drug, but a Victoria trial came out and shown that if you've had an EF less than 45 with worsening heart failure symptoms or a recent heart failure hospitalization, that adding it would reduce hospitalizations and death, but again, mostly driven by a reduction in heart failure hospitalization. And the reason it really hasn't taken off is that it causes hypotension. And so I find by the time I get my patients on all these 4 drugs, to add yet their blood pressures are, as you can imagine, aren't very high already with, ejection fractions that are low with all these medications. So symptomatic hypotension is a risk to avoid. And so again, not commonly used. So the last thing I'll focus on before handing it back over to Juliet is just some more points on how heart failure affects your perioperative risk. So as Juliet mentioned, heart failure increases perioperative mortality and morbidity, but the phenotype, their symptoms, the stage of their heart failure, the severity will further influence their risk. And so if you look, a nice study by Smilowitz looked at a huge population of 21 million surgical hospitalizations, and about 4.9% of them had heart failure, and they basically showed a higher mortality with any diagnosis of heart failure, 4.8 versus 0.78%. And it was higher regardless of what surgery you were going for, although orthopedic surgery tended to be the highest in that group. They're not just having problems with heart failure during that perioperative admission, but they're at increased risk of other cardiovascular complications, such as a postoperative MI, a stroke, a PE, or cardiac arrest. And the greatest mortality, as I kind of alluded to previously, are those with new acute decompensated heart failure, up to 8% mortality versus acute on chronic had a little bit less, and then the chronic kind of more stable heart failure, about 3.9%. So be wary of the decompensated patient. Another study in the US looking at a predominantly male population in the Veterans Affairs group, again showed higher risk of 90-day perioperative mortality. And just going to show that symptomatic patients had the greatest risk for mortality as compared to asymptomatic patients. And again, though they are at higher risk of any other perioperative complication as well. So cardiac arrest, MI, stroke, bleeding, even surgical site infections. What happens when you risk stratify by ejection fraction? Not surprisingly, the worse your ejection fraction, the worse your mortality is. So, those with HFpEF, their crude mortality was about 4.8%. By the time you get down to ejection fractions less than 30%, the risk of mortality was 8.3%. And again, just at the bottom of that table, you'll see comparing symptomatic versus asymptomatic patients with crude mortalities in the symptomatic patients of 10%. So key thing to focus on is ejection fraction, which can help you risk stratify, as well as do they have compensated symptoms or not. Is there anything else besides ejection fraction on echo that might help you? Well, right ventricular function has been shown to be a good predictor. So the TAPSE, which is a marker of the tricuspid annular motion, and is one qualitative measure or quantitative measure of right ventricular function, has been shown to predict perioperative complications. So if their TAPSE is less than 17 millimeters, or we often report in centimeters, so less than 1.7, those patients are at increased risk. This has not met any dedicated guidelines yet, but if you have that echo, it's useful to consider. BNP, however, has made guidelines, particularly the Canadian Cardiovascular Society guidelines, as a useful risk predictor. And so BNP is made by the myocardium in response to ventricular stress and wall tension, and it is recommended for anybody who would have a baseline risk of more than 5% of cardiovascular death or non-fatal MI. And so based on the VISION trial, that population would be anybody over the age of 65 should have a BNP done, anybody with between the age of 45 and 64 with significant cardiovascular disease, or those with a revised cardiac risk index score of greater than 1. So the RCRI score, heart failure is a component of that. And so basically any patient with heart failure gets an RCRI score of 1. And so all of them should have a BNP. And it's pretty much going to be elevated in all of them, except for, I have a couple patients who have reduced ejection fractions that walk around with a normal BNP, but that's certainly not the norm. So what may be more useful in them, because you already kind of know they have heart failure and that they're at elevated risk, but that BNP, an increase or decrease from their baseline, can tell you about, if they've kind of been sliding from their baseline, or whether they're pretty stable and they're probably as good as they're going to get. The data for the BNP comes from a meta-analysis that looked at a cutoff of a NT-proBNP of less than 300, and those who had higher BNP was independently associated with adverse outcomes, death, and non-fatal MI after non-cardiac surgery. And it basically helps further risk stratify those patients. And so in the VISION study, they had patients over 45 with non-cardiac surgery staying over at night, and they followed them for about 30 days, and about 17% of that population had heart failure. And you can see 17% had BNPs less than 200, 42% between 200 and 1500, and 40% had BNPs over 1500. And you can see in the table below how that BNP level affects your all-cause mortality and MI, so that once you start getting patients with BNPs of over 1500, you can see that there's a significant 15.8% or perhaps even higher risk of all-cause mortality or death. There is a calculator where you can use that. So on QXMD, where you can put the patient factors in and the BNP, and it will give you a more patient-specific risk calculation. So with that, I'm going to hand it back to Juliet.
Thank you, Sarah. So Sarah covered the heart failure portion of our patient, but what about the other stuff we need to know? What about their other comorbidities and risks? So she reviewed data about high-risk heart failure parameters, this symptomatic or asymptomatic, the echo features, either EF, RV function, diastolic dysfunction, and BNP levels. So what else will help us assess how patients' risk and prognosis for an individualized risk assessment? And we're going to talk about things that are as important, like frailty, because a 20% EF who's frail is very different than an EF of 20% who's carrying out normal activities or has a good good functional ability. We're going to talk about comorbidities and functional capacity. And then how do we put this together to communicate to the care team, the patients, and the family? So starting with frailty, like I said, this is as important, if not more important, for all our preoperative assessment for our patients. And the ESC says patients who are over 70 who require intermediate or high risk non-cardiac surgery should include frailty screening. They even put it in a table. And I would submit that if you have a patient who has a lot of comorbidities, that they should be screened even earlier than 70 years old. Just to back up, what is frailty? Frailty is defined as an age-related syndrome of physiological decline and reduced tolerance to medical and surgical interventions. So the reduced tolerance to medical and surgical interventions is actually built right into the definition of frailty. It's multifactorial. Age, chronic comorbidities, and disability are associated with frailty, but not diagnostic. And it's a spectrum, with the end stage being failure to thrive. Frailty is really important, and it's been studied a lot, but it also makes it confusing to actually put into practice. This 2016 review looked at all the different frailty tools, and they found 67 different frailty instruments. And there was a wide range of agreement of whether a patient was frail or how frail they were in the same population. And they too often fail to differentiate disability, comorbidity, and frailty. This clinical frailty scale is widely used from Dalhousie University, quick and easy, and improves measures of predictive performance. So it's a good one to keep in mind, and it's phenotype-based. How common is it? Well, 4 to 16% of the general population above 65, but with patients with cancer, older patients, up to 43%, and patients coming for surgery who are older, non-cancer surgery, 30%, cancer surgery as high as 50%. And it's really common in our critically ill surgical patients. And how bad is frailty? It's really bad. So the study looking at frailty and postoperative mortality showed that for even low intensity specialty, the adjusted odds ratio was extremely high, and also high in the frail and very, very frail. And I think this is just that patients who were very frail still underwent things like plastic surgery, thinking that it would be, no big deal. They concluded that frailty is a consistent independent risk factor for 30 and 180-day mortality across all specialties, independent of operative stress and emergency status. This study looked at frailty in emergency abdominal surgery, and it was over 4 times higher mortality. And they're more likely to experience all complications. This looked at frailty and operative stress, published in JAMA in 2020. And for frail patients, the 30-day mortality was 5.3%, and for very frail, up to 18.7%. And the mortality at 180 days for moderate risk surgery in very frail patients was 43%. They concluded that mortality rates for frail and very frail patients were alarmingly high across all levels of surgery compared with stronger patients. And they said that frailty screening should be applied universally because low and moderate stress procedures may be high risk among patients who are frail. This study also in JAMA looked at mortality after elective and emergency surgery, and they concluded that frailty remains a primary factor associated with postoperative outcomes. And so why is it important to assess? It's actually the best marker we have for determining high risk across surgical intensities. And so we know in the moderate to severely frail patients that less is more for these patients. Aggressive screening and intervention can cause harm. And even procedures and hospitalizations can cause burden and impair the quality of life further. So if a patient is frail, these are the patients that we need to focus on goal concordant care. And sometimes this even means operating if quality of life will be significantly improved, even if the risk of the surgery is high. But often palliative care is the most appropriate intervention. We are just starting to realize this and implement this in perioperative medicine. And at VGH, we have a group of physicians who actually undergo frailty screening for patients who are booked for surgery and try and identify them early. And then they get triaged to a separate clinic and for geriatric medicine assessment. And this is a program we're just starting for these patients. So what about comorbid cardiovascular conditions in this patient and other patients? The key message from the ESC that pre-existing or newly diagnosed cardiovascular conditions, treatment should be individualized according to the risk of surgery and according to specialty guidelines. And they recommend a multidisciplinary approach. So our patient in the clinic who has heart failure could have a variety of other comorbid cardiac conditions. This is when the guidelines become especially useful. A patient should also have a cardiologist, so any new symptoms or concerns should prompt discussion with them in terms of further investigations or management that would be most appropriate. So here is just an example of the montage from the ESC 2022. So recommendations for preoperative assessment in patients who have previous unknown murmur, angina, dyspnea, or edema. And then all the recommendations for valvular heart disease in patients undergoing non-cardiac surgery. And then patients with specific diseases undergoing non-cardiac surgery, like pulmonary hypertension, renal disease, cerebrovascular disease. And then patient-related and surgical-related factors to be considered for a patient who has pulmonary hypertension, recommendations for patients with pulmonary hypertension, recommendations for patients with congenital heart disease, and risk stratification for adults with congenital heart disease. So there's a lot of really great information that we don't really have time to go into any great detail here. As I just want to plug this article, if you're interested in cardiomyopathy and anesthesia, in the British Journal of Anesthesia Education, it has a really useful systematic approach for cardiomyopathies that's worth reviewing. What about functional capacity of our patient? Another key message is that clinical patient-reported functional capacity is a cornerstone of preoperative assessment. So poor functional status is defined as the inability to walk 4 blocks or climb 2 flights of stairs. And it's pretty sensitive and moderately specific for serious postoperative complications. And it's a linear relationship. METs are thought to be more subjective, and they're not shown proven value in large studies. So back to our patient. He's in the clinic. His EF is 20%, and he's coming from moderate risk OR. Our goals for assessment for him for heart failure include risk assessment and modification. So we want to tease out all these factors that would make him high risk. We want to know the etiology and trajectory, because specific etiologies have specific considerations, like congenital heart disease or HOCA, RV function. Are they stable? Are there signs of decompensation? Any new signs or symptoms that require further investigation? And are they on optimal medical therapy that Sarah taught us about, both medical and device? And it's advised that they're on ideally 3 months of stable heart failure treatment to be optimized. And then are there any high-risk heart failure patients or syndromes, such as decompensated heart failure, advanced heart failure, RV dysfunction, pulmonary hypertension, congenital syndromes? They should be followed by a heart failure cardiologist, so we should get consult notes and most recent investigations. By history, we look at symptoms, functional capacity, talk about comorbidities. It's really important to identify coexisting conditions and triggers for heart failure, new conditions, and then frailty. If greater than 70 per the guidelines, that I would submit that possibly even earlier starting frailty screening if there's any concerns. And then physical exam for heart failure. In terms of investigations that are important for these patients, BNP, Sarah talked about, very sensitive, not really specific for heart failure. ECG can be diagnostic and provide prognostic information and a baseline for comparison. If you suspect there's worsening or increased pulmonary edema, you can do a chest x-ray. An echo recommended if a patient has heart failure and an intermediate to high risk procedure and a suspected undiagnosed heart failure cardiomyopathy, a change in heart failure clinical status, or no assessment of LVEF in the past year. Also, if there's concern for an undiagnosed severe obstructive abnormality, like stenosis or HOCM or severe pulmonary hypertension. And there's also a table for recommendation of management of heart failure in patients undergoing non-cardiac surgery. And at the bottom there, multidisciplinary team if they have mechanical circulatory support. So back to our stepwise approach. We need to integrate these clinical risk factors, the test results, the estimated stress of the procedure, and the risk of discontinuation drugs. And it's all about really trying to do an individualized patient risk assessment. And this risk assessment is our attempt at putting it all together. And it's a key recommendation to do this risk assessment and initiate risk reduction strategies to help reduce risk. And they say, ideally at the time that non-cardiac surgery is proposed. This is still a pipe dream in our department and many anesthesia departments across the world. But we're trying to do a better job of this through that frailty screening program. The EC also says that we should ensure well-informed patients are involved in decisions and that the risk should be communicated to patients in absolute terms. Well, how do we do that? And the answer that many people have come up with is risk scores. And these are our attempts to quantify the patient's risks for non-cardiac surgery. And there's so many of them, it can be confusing. They're based on lots of different variables and methods and patient populations. And none can be perfect because every patient is individual and they're not a crystal ball. The two most recommended and validated for cardiac patients are the Revised Cardiac Risk Index and the American College of Surgery National Surgical Quality Improvement Project. And they both have discriminative abilities for predicting any MACE. And these are the ones that are often quoted in our internal medicine consults. So let's go over these quickly. The RCRI estimates the 30-day risk of MACE. There's only 6 variables: high-risk surgery, history of ischemic heart disease, history of heart failure, history of cerebral vascular disease, diabetes, and renal failure with specific creatinine cutoffs. It's the most validated for MACE, but it was based on a relatively small patient sample, and is thought to have moderate diagnostic accuracy. The AHA 2014 guidelines use the original risk estimate, so you only need one risk factor to get a 1% risk of MACE. And so one risk factor, MACE greater than 1% risk. They recommend further testing based on the guidelines. If you have risk greater than 1%, only if you have poor functional capacity and if it will change management. They redid this data with biomarkers added, so postoperative MINS, and the risk scores changed significantly. So a score of one risk factor is a 6% risk. and then greater than 3 is a 15% risk. And these are the numbers that the CCS, the Canadian Cardiology Society, recommends, but it's conditional recommendation based on low quality evidence. The ACS NSQIP is an interactive online calculator. It's a very large contemporary registry. It does take the procedure into account, so you can pick the procedure or the code, and looks at the absolute 30-day probability of complications versus the average patient. So the downsides is the MACE definition doesn't include postoperative heart failure, and they didn't use MINS, and it doesn't include all risk factors such as ischemic heart disease or recent myocardial infarction. So these are the factors involved. And so how many of us use risk scores? When I asked this question in the CAS, it wasn't many of us. However, the CCS good practice statement says the patients who undergo elective surgery who are greater than 45 years old or younger who've had cardiovascular disease, they recommend that undergo perioperative cardiac risk assessment. Up to date takes a more practical view in the perioperative heart failure. They say our experts don't routinely use, but if warranted, use RCRI or ACS NSQIP, as both models include heart failure. So risk models are a little bit controversial in whether they're helpful to us, but the guidelines do also recommend that we put numbers on patient risks. So we're a little bit stuck, and it's partly because this study published in Anesthesiologist showed us that the risk models disagreed about 30% of the time on whether the patient was low risk versus elevated risk of MACE. But I don't think we should throw them out altogether. They don't always agree on risk category, but most of the time they do. There's also lots of variation in percentage predicted risk between the risk tools. So it's important to understand what they are. And there's significant, if there is significant divergence, we need to do a bit of a deeper dive. We need to figure out which one best reflects our patient and incorporates risk factors that we know are important for our patient. So here's a little case example. Is this Mr. RW is an actual patient that I looked after. He was 90 years old, functioning independently at home, but had multiple comorbidities. He presented with anemia, dark stools, admitted under internal medicine. He was at apixaban for AFib, which was held due to bleeding. He had heart failure, reduced ejection fraction with a BNP greater than 4,000. NYH rate 3, but otherwise asymptomatic of cardiovascular disease. His heart failure meds were held because of acute on chronic kidney injury. He was noted to be a full code, stable on ward, and unfortunately, his CT showed an obstructed ulcerated hepatic flexure with mets to his liver, lung, and spleen. And he was booked for MIS right to me. It was thought that his quality of life would be poor based on his ongoing bleeding, his need to be defibrillated, and pending obstruction. But we can all, I think, tell that this patient is high risk for surgery. Can we quantify it? And can we quantify it using our risk scores? Are they helpful? So if we look at the surgery type, it's a moderate risk surgery, so 1 to 5% risk of MACE. Seems a little bit low. If you look at his RCRI score, he only gets a 1. So 1% risk of MACE at 30 days, or 6% if you include MINS. And of note with the RCRI score, the highest number you can get is 4% risk of MACE, or 15% if you add post-operative components. And if we remember with the frailty scores, the numbers get much higher. So that doesn't seem very accurate or helpful either, if we want to communicate risk to this patient. So the ACS NSQIP gives more parameters, including frailty, and gives multiple outcomes, including death and disability. And this is just a little reminder and a summary of all the other numbers we talked about and how high the risk can be in terms of mortality for frailty and mortality for certain high-risk heart failure features, including the BNP which for him was greater than 4,000. Plus, it's not elective surgery, etc. So, if you plug all his parameters into the NISCA risk calculator, it gives you a table like this, which was actually fairly helpful. It will email it to you, and it comes in a printable version so that you can actually give patients and families a copy. So it estimated his risk of serious complications at 28%, cardiovascular complications 11%, which seemed maybe a little low to me, death at 44%, a discharge to a rehab or nursing facility, which is often important for patients, at 64%, and then functional decline at 78%. So I did find for this patient that these numbers were a little more useful. The problem with risk scores and specific comorbidities, like for a heart failure patient, is that heart failure is treated as binary. It's present or it's not. And it only makes up 1 point of the RCR. It doesn't include high-risk cardiac conditions. And we know our patient risk increases with the things we talked about. So risk scores are not the bottom line. They're worth calculating the guidelines. They're always being perfect, but the best we have. They can add valuable information to the discussion, but you need to know what they offer versus the limitations. Don't just go with the calculated. Ask yourself if there's face validity. Does it include risk factors that would be reasonably associated with risk of MACE for the patient? And determine how they will add to key decision-making preceding the surgery and the value of further evaluation. And this is a bit of the art of medicine. So the other factor in this is, now that we've tried to determine the risk, we need to communicate this to the patient and ask them how they feel about their risk of disability, discharge to a nursing home, what they want in terms of care, to come up with this elusive shared decision-making. Key ESC message is to consider patients' values, quality of life, and preferences with regard to the best risks and benefits of surgery. And a goal of care discussion is crucial in this. If a patient is frail or high risk, you want to establish priorities, weigh risks, benefits, and alternatives, create realistic expectations, and better informed decisions about the aggressiveness of care intra-op, but also to make sure that we provide goal concordant care post-operatively, especially if the patient will not be in a position to be able to answer these questions. And you can consider palliative care consult to help with this. One of the ways that we're all trying to be better at this is by having more serious, honest conversations with our patients. We have a cardiologist, Dr. John Weisler at Lionsgate Hospital, who made it a QI project that all physicians in the hospital trained with workshops in serious illness complications, because we don't have the palliative care resources for them to consult on all the patients. So this RPACE stands for Regional Palliative Approach to Care. And it's the website has great resources and education around this topic, identifying patients who need this conversation. And it's not just about whether they need CPR or whether they want to be transferred to ICU. It's about what matters most to the patients, the goals, the values, develop patient-centered goals and recommendations for care, and explore what-if scenarios. And the Serious Illness Conversation Guide is a validated tool and framework to assist clinicians in having these conversations. So I would really recommend looking into this and getting more comfortable with this, as we're all trying to be. And this is sort of their summary sheet that little pocket wins as well into how to best approach this with patients and families. And then this elusive shared decision-making for frail or high-risk patients, recommending a geriatric medicine consult, a multidisciplinary team, a treating physician, anesthesiologist, geriatrician, patient, family, and other specialists like their cardiologist. This can improve prognosis and positively impact patient experience. And the goal is to provide the right kind of care for each unique patient and circumstances. You want to consider, is my site appropriate? you need to consider the whole perioperative team. I know there's many skilled surgeons and anesthesiologists in the community setting, but where they're going post-op, do you have a monitored bed? Do you have post-operative internal medicine? They're not going to just be lost on the surgical floor. Is equally important for heart failure medication titration and early detection of complications. And also consider what bailout options are most appropriate. If things go wrong, do they qualify for advanced heart failure therapies? Does your site accept ICD? And what are the patient preferences, and are they willing to accept the risk? And if we proceed, we need to optimize care, optimize treatment for heart failure, stabilize the patient if they're unstable, if there's time, ensure post-op care available, post-op goals of care, and prehab may improve prognosis. So just a quick story about a patient I had in clinic who was coming for redo sternotomy. She was in her late 70s, and she'd gone through her cardiologist and her cardiac surgeon, and she was high risk. And I was trying to communicate this risk to her. She had pulmonary hypertension. She'd had previous stroke with her previous surgery. She had RV dysfunction. And she said, that's what I try to keep telling people, that I feel like I'm high risk and people keep telling me to have the surgery. And so we had a complex case discussion about whether edge-to-edge tricuspid repair would be appropriate for her, and it wasn't. But we had a cardiologist and the palliative cardiologist. And then we had another group discussion about her goals. And despite telling her that her mortality was in the range of 2 years with severe symptomatic tricuspid regurgitation, she ended up electing to have the surgery and to spend Christmas with her grandchildren, etc. And when I went back and talked to the cardiac surgeon, he said, he's like, oh, do you think more patients don't really want surgery, but they're too scared to tell us? And I said, no, I think that was the only one. I think it was a bit of an eye-opener for him in terms of patients do tend, especially older patients, tend to just go with the flow and go along with what they see as recommended or what their doctors want. And if we don't ask them, we'll never know what their true wishes and goals of care are. And I'm going to hand over to Sarah again for further discussion of risk optimization and management.
As Juliet mentioned, proceeding versus canceling surgery should be a shared decision-making by that multidisciplinary team. Emergency surgery, well, time is quite limited, and in those with advanced or severe heart failure, really have to balance whether that surgery is actually going to change the patient's outcome, because those with advanced heart failure, their mortality is dictated by that heart failure phenotype regardless. Urgent surgery, obviously you can proceed if they're fairly low risk in that spectrum. If they're decompensated, try and delay if possible to try and optimize, and obviously cancel the surgery or explore alternatives or palliative care for those who are their surgical risk exceeds the benefits, and particularly those patients with NYHA4 heart failure, decompensated heart failure, shock, pulmonary hypertension, or severe frailty. For elective surgery, this is I think where you have the most opportunity to intervene. And so if it's new heart failure, again, you want to delay about 3 months. We can make a lot of difference. And I've seen ejection fractions, come up significantly with 3 months of optimal medical therapy. If you don't have a lot of time, at least 1 month, and to try and further optimize, and again, cancel if the risk outweighs the benefit. My rainbow in all of this, if I had the ideal patient, they should be euvolemic before elective surgery with stable blood pressure, optimal end organ function, all their medications are properly adjusted before the case. In the grand scheme of things, that's not always possible, but that's the rainbow. A few comments just on what to do with their heart failure meds preoperative. The ACE, ARB, and ARNIs is a matter of debate, and you actually see different guidelines recommend different things. So the ESC has said it may be reasonable to actually continue the ACE, ARB, ARNI perioperatively, although that's based purely on expert opinion. Up to date, I think, is the most balanced and sensible approach and probably where I'd go. So I would continue it if they are stable with low risk of hypotension. So they've come in with relatively normal blood pressures, your risk is kind of low to moderate risk of surgery, might be reasonable to continue that, but I would hold on the day of surgery if they're coming in with relatively low blood pressure. CCS did recommend holding these ACE ARBs before surgery. There's no perioperative data on the ARNIs at all. Anecdotally, you will hear horror stories of severe vasoplegia. So again, I would say, especially, I would probably hold your Entresto on the day of surgery, or even a couple days before, if they are kind of hypotensive at baseline. If, again, you have a patient who tends to have that more hypertensive heart failure phenotype, then that might be the patient that you continue it with. But be wary of it, and I think that's a good discussion that you want to have with their heart failure specialist. You don't want to decompensate them right before their surgery by holding it, so it's a balance. If you hold it, the biggest thing is restart it post-operatively, because if you don't, that's where the increased mortality comes in, is when these medications don't get restarted and they go home on no heart failure therapies. Beta blockers, as you know, should generally be continued if they're already on it. Avoid starting it in the pre-op setting if they're not on, especially, that high dose metoprolol on the day of surgery. That's not the ideal from the old boys too. SGLT2 inhibitors, you want to hold at least 3 days per surgery. There's a concern for euglycemic DKA. MRAs, usually you would continue as long as they're stable renal function and normal potassium. Hold, obviously, if that's not the case. Digoxin is generally continued. Diuretics depends on their volume status and their electrolytes coming in. And vericiguat, there's absolutely no data. I would probably hold it. Don't forget about all the other medications that they will likely or may be on, like antiplatelets, anticoagulants, statins, antiarrhythmics, other blood pressure agents, which the perioperative guidelines do a good job of telling you whether to continue or not. These patients may often have ICDs or CRT devices that you should chat with the device clinic about how best to manage them perioperatively as well. So in summary, heart failure patients are some of the highest risk patients for perioperative morbidity, mortality. Careful pre-op risk assessment, exploration of those patients' gold. Perioperative optimization is necessary to try and reduce adverse events and perioperative outcomes. And shared decision-making with multidisciplinary teams is key to ensuring that the patient has the appropriate understanding of the risks and benefits of their surgery, whether to proceed with surgery at all, to optimize their perioperative management, and to explore alternative options or palliative care if surgery is not the right thing for them.
You've been listening to Airway Breathing Conversation, a podcast hosted and presented by the anesthesiology residents at the University of Saskatchewan. Please note that while this podcast is run by healthcare professionals, it is intended for educational and entertainment purposes only. We are very thankful to our guests for taking the time to share their wisdom with us this episode, and a very special thanks to you, our listeners, for tuning in. Don't forget to follow us and our associated USask Anesthesia accounts on social media. You can find all our social media links on our Linktree page at linktr.ee/abc_podcast. You can also find the department's social media links on their Linktree page at linktr.ee/usask_anesthesia. We'll see you next episode, but until then, stay calm, take a breath, and always remember your ABCs.